We will continue discussing the EFAS study. So the suprapubic view, there's one space that you should interrogate, which is the retrovesicular recess or pouch of Douglas. Let's review some anatomy. Any fluid present in the intraperitoneal cavity most likely will accumulate first in Morrison's pouch when the patient is lying supine. With any overflow traveling down the right paracolic gutter into the rectovesicular space in males and the rectouterine space, also known as pouch of Douglas, in females. Similarly, fluid in the splenorenal recess on the left side may overflow and travel down the left paracolic gutter into the pelvis or over to Morrison's pouch on the right side. So the important spaces that you're going to interrogate is the rectovesicular space in males and the rectouterine space or pouch of Douglas in females. To evaluate the suprapubic view, it's best done before the bladder is emptied by placing a Foley catheter. It is much easier because you use a full bladder as an acoustic window. You should evaluate the space in two views: the longitudinal view, where the probe marker is placed towards the patient's head or cephalad, and the transverse view, where the probe marker is facing to the patient's right. Place the probe in the transverse position, probe marker to the patient's right, on the symphysis pubis and angle towards the patient's feet. Remember, the bladder is not always perfectly midline, so it's sometimes sliding to the right and left above the pubis symphysis will bring the bladder into view. The most common reason for difficulty visualizing the bladder is a probe position that is too superior. Remember that the bladder is a pelvic organ and only emerges from above the symphysis pubis as it becomes distended. Once the bladder is identified, transversely rotate the probe 90 degrees for a longitudinal view. It is important to fan anterior and posterior in the transverse views and slide right to left when you get the longitudinal view in order to fully interrogate this space. These are representative ultrasound images of the both views. Examine the fluid posterior to the bladder or posterior to the uterus and in between the loops of bowel. It is important to look in both the transverse and longitudinal plane for fluid behind the bladder, as the sagittal, or also known as the longitudinal view, is more sensitive for a small amount of fluid when compared to the transverse view. Because free fluid outside the posterior bladder wall is easier to identify in longitudinal plane. Moreover, occasionally if the bladder is very full, the transverse view is obtained higher in the peritoneal cavity, so the most dependent part of the pelvis, which is the rectovesicular space, is missed. These are normal images of both the transverse and longitudinal view in females and males. As you can see, the black fluid-filled structure is the bladder. Let's go through some examples. What do you think of these videos? So these are examples of normal suprapubic view in a male and a female. Looking at the ultrasound image on the left, so you can see they start with a longitudinal view and then they change it to a transverse view. And you can see a fluid-filled bladder and a normal rectovesicular space. There's no free fluid behind the bladder. While looking at the ultrasound image on the right, it's a female pelvis. You can see they start with a transverse view and then they change it to a longitudinal view. And you can see the fluid-filled bladder and posteriorly the uterus and there is no fluid in pouch of ductus. How about this clip? So you can see a fluid-filled bladder, and posteriorly there is a large amount of free fluid. And this is a longitudinal view. So this is a positive pelvic view. Let's see another example. So this is a transverse view, and you can see the bladder that is filled with urine. Posterior to the bladder, you can see the rectum. And this view is positive for free fluid in the rectovesicular space that is extending posteriorly, that is demonstrated by the red arrows. This is another example. Is this a positive suprapubic view? So looking at this image, you can see that definitely the bladder is distended and filled with fluid. And if you don't concentrate well or you fan too fast, you might miss the small amount of free fluid. I'm going to pause the clip and show you a representative picture so you can see the bladder, and this is the small amount of free fluid in the rectovesicular space. How about this patient? What do you think of this image? This is a transverse view where you can see the bladder is very, very distended, and you might not appreciate it very well, but there is small amount of free fluid there, demonstrated by the red arrow. This is the same patient, but with a longitudinal view. Here you can clearly see easily the free fluid behind the bladder. It's very important to remember to adjust the gain to make sure that the brightness of the image is adjusted appropriately so you can appreciate free fluid, because if the gain is too bright, you might have large amount of posterior acoustic enhancement, which is a normal artifact because the bladder is fluid filled, and then you can miss the free fluid. Remember again, we discussed earlier that the longitudinal view is more sensitive, especially when the bladder is filled, because if you scan in the transverse area only, you might miss the most dependent part of the pelvis, which is the most inferior part. How about this video? So this is a normal suprapubic view in a male patient. As you can see, the bladder, with posteriorly you can see the rectum and the seminal vesicles that can be mistaken as free fluid. So this is a very important pitfall that sonographers can call the rectum or the seminal vesicles as free fluid. So this is side by side what a normal suprapubic view in a male looks like, and on the right you can see the free fluid. Remember again, free fluid usually is triangular in shape. They have very sharp margins. When you compare it to other normal fluid-filled structure, they're usually circular and they're surrounded by walls. How about this view? So this is a suprapubic view, but obviously you can't really see the bladder. The bladder is decompressed by a Foley catheter. This circular structure that you see is the Foley catheter, making the evaluation of the suprapubic view limited. Therefore, if you're performing this fast exam is going to be inconclusive because you can't really evaluate the suprapubic view as the bladder is decompressed. So let's go back to the original questions we had when performing the FAST exam. So we said we're going to try and answer 4 questions. So far, we reviewed and are able to answer 2 questions. Is there intraperitoneal hemorrhage? And it's important to note that you need all 3 views and you need to evaluate all 9 spaces to be able to exclude intraperitoneal hemorrhage. If any of these views are positive, you don't need to perform the rest of the exam. It's a positive study. But if any of these views are inconclusive, that means you could not evaluate the potential spaces, you can't call this exam negative. The exam is going to be inconclusive. The second part we were able to answer so far is the evaluation of the peritoneal cavity for hemothorax. So we remain 2 important questions. Is there traumatic pericardial effusion and is there a pneumothorax? So again, quick summary of what we covered so far. We looked at the right upper quadrant. There are 4 potential spaces there. The left upper quadrant with 4 potential spaces and the suprapubic 2 views with 1 potential space. Remember, you need all 3 views to be negative to call it a negative FAST exam for intraperitoneal fluid. But if any of these spaces are positive, you don't need to continue because that's a positive study for intraperitoneal fluid. We have one more view to evaluate, which is the sub-xiphoid view, and you're evaluating the pericardial space looking for traumatic pericardial effusion. A quick review of the anatomy. So to evaluate for pericardial effusion, you want to evaluate the pericardium where the fluid collection is going to surround the myocardium. For the sub-xiphoid view, position the probe almost flat on the abdomen with a marker to the patient's right and angle the probe to the patient's left shoulder. If the patient can bend his or her knees, sometimes this can help relax the abdominal wall muscles. Sometimes a stomach full of air can scatter the ultrasound beams before they reach the heart in the left chest. If this is a problem, slide the probe to the patient's right and shoot through the left lobe of the liver. The liver will act as a better acoustic window than the stomach, and the heart will be easier to visualize. This is a representative image of the sub-xiphoid view. So in this image you will see that the chamber closest to the liver is the right ventricle, and right above that is the right atrium. You can see the interventricular septum and the left ventricle and the left atrium. And the surrounding white structure is the pericardium. And that's where you're going to look for anechoic or black fluid collection indicating pericardial effusion. It is important to remember to bring the depth out to its maximum level for this view, because often the distance from the sub-xiphoid to the heart is at least 6 cm. With a shallow depth setting, the heart will not be visualized. Let's go through some examples. So what do you think of this clip? So this is a normal sub-xiphoid view. Let's just get oriented with the anatomy. So this is the liver. The first chamber closest to the liver is your right ventricle, then the right atrium, and you can see the tricuspid valve between them, and then the left ventricle and the left atrium, and you can see the mitral valve between them. For the purposes of a FAST exam, you're interested in evaluating the pericardial effusion. So the white structure is the pericardium, and if there's any fluid, it's going to be just above the pericardium, between the pericardium and the myocardium. So this is a normal sub-xiphoid view. You can't see any evidence of pericardial effusion. How about this image? So obviously you can see that there is a large amount of anechoic or black fluid collection surrounding the heart, and this is a circumferential large pericardial effusion. So this is a positive sub-xiphoid view for a pericardial effusion. Moving down to the next example, what do you think of this image? Again, this is a sub-xiphoid view of the heart, and you can see that there is a pericardial effusion there. This is another case. So what do you think? So in this video, you can obviously see that there is no cardiac activity. That's a very important point. But what I wanted to bring up here is that this patient has both a clotted pericardial effusion as well as a fresh pericardial effusion. If you can see, there is hypoechoic or echogenic material surrounding the pericardium. That is clotted pericardial effusion, and also you'll see some fresh pericardial effusion as anechoic or black fluid collection. So far we are able to answer 3 important questions when performing an extended FAST exam. We reviewed how to evaluate for intraperitoneal hemorrhage. We evaluated the pleural cavity for hemothorax, and we discussed how to evaluate the pericardium for traumatic pericardial effusion. The next question we will answer is there a pneumothorax or not? You can perform the scan using a high-frequency or a low-frequency probe. We would prefer using a high-frequency probe as the image detail and quality is better compared to the low-frequency probe. But many hospitals only have one probe with their ultrasound, which is the low-frequency probe that you use for your FAST exam. If that's the case, you can still use the low-frequency probe to perform this exam. To perform this exam, you use a low-frequency probe, which is placed in the anterior chest wall while the patient is lying supine. Place the transducer over the 3rd or 4th intercostal space anteriorly. First, identify the rib shadow. This allows you to allocate the intercostal plane. So you'll identify the rib shadows with posterior shadowing, and the hyperechoic line or the white line between the 2 rib shadows demonstrate the pleural line. Once you identify the pleural line, it's a hyperechoic line located between 2 ribs. One of the most important things to remember when evaluating the thoracic cavity for pneumothorax is that the probe can only interrogate the area of the pleura directly beneath the probe footprint. Therefore, if the patient is upright, the most important place to look for a pneumothorax is the apices bilaterally. If a patient is supine, the most important place to look for a pneumothorax is the anterior chest wall. If a patient has a penetrating trauma or has just had a procedure, the most important place to look for a long sliding is directly below the point of penetration. Obviously, looking in more places increases the sensitivity and specificity of your exam. So in a normal subject, the pleural line is characterized by lung sliding. You can see that the pleural line is moving with respiration. You should also look for cometail. I'm going to freeze this image to demonstrate what a cometail looks like. So this is a normal lung sliding of the pleural line. And this is a frozen image showing a cometail, which is a reverberation artifact originating from the pleural line. Normal lung sliding and the presence of cometail artifact rules out pneumothorax with a 100% negative predictive value. If you only have a low frequency probe, you can still perform the study. to evaluate for pneumothorax. Make sure you decrease the depth enough that you can evaluate the pleural line. So here you can see the ribs with the posterior rib shadows, and the white structure in between them is the pleural line. Make sure you zoom in and look for lung sliding. Like I mentioned before, the image detail can be affected because this is a low frequency probe. You can use M mode to demonstrate lung sliding on a static image. When using M mode for this technique, follow a line that includes the subcutaneous tissue, chest wall musculature, pleura, and lung, and make sure to avoid placing the M mode line over the rib. In a normal lung, the image obtained using M mode should demonstrate smooth lines superficially, because the chest wall should not move much with respiration in this view. Deep to the pleura, the sliding lung will produce enough motion artifact to create a rougher, grainier image. The interface between the smooth line of the chest wall and the rough texture of the moving lung has been described as waves on a beach or a seashore sign. So I just want to demonstrate this yellow line is the pleural line. Above this line, you'd see a static image. There's no movement of the chest wall. And below that, you'll see grainier image demonstrating the movement of the pleural line. So this is a normal lung sliding demonstrated using an M mode showing a seashore sign. Just placing side by side what a normal lung should look like using the 2D image with the normal lung sliding and comet tail. While in pneumothorax, you won't see any lung sliding. And if you use an M mode to demonstrate the difference between them, on the left side you can see the seashore sign showing the movement of the pleural line, while on the right side you see the barcode sign indicating that there is no motion visible below the chest wall or the lung. Therefore, the line will be uniformly straight and smooth. Let's go through some examples. So what do you think of this video? So this is again normal line, a pleural line demonstrating lung sliding and comet tails. This can rule out pneumothorax with 100% negative predictive value. How about this video? You can clearly see that the pleural line does not demonstrate lung sliding. So in case of trauma, you are very suspicious of a pneumothorax if you see this. How about this clip? This is known as a lung point, one of the most specific signs for pneumothorax. This is where the area of the pleura reattaches, and it is represented by an ultrasound image with half of the lung is not moving and the other half is sliding normally. This is known as the lung point. The lung point can be demonstrated on an M mode with a still image by showing half of the image as a seashore sign and the other half as a barcode sign. What do you think of this video? So in this video, you can see what is known as a lung pulse. The lung pulse refers to a rhythmic movement of the pleura in synchrony with the cardiac rhythm. It is best viewed in areas of the lung adjacent to the heart, at the pleural line. The lung pulse is as a result of cardiac vibration being transmitted to the pleural line. in a poorly aerated lung. Cardiac activity is essentially detected at the pleural line where there is absent lung sliding. In normal, well-aerated lung, the lung pulse is not present, as the lung sliding becomes dominant and resistant to cardiac vibration. And this is an M mode demonstrating a lung pulse. You don't really see obvious pleural movement, but you can see this rhythmic pleural movement with cardiac activity. So far, we have gone through the whole extended FAST exam, and we are able to answer 4 of the most important questions. Is there peritoneal hemorrhage? Is there hemothorax? Is there traumatic pericardial effusion? And is there a pneumothorax? In the next slide, I will review some papers on the sensitivity of FAST exam for these findings. There are a number of studies that have been published on the sensitivity of FAST exam in the setting of trauma. In evaluating intraperitoneal fluid, the consensus between the studies that the sensitivity of a FAST is between 73 and 88%, and the specificity is as high as 98 to 100%. And you can see the numbers are even better for evaluating hemothorax as well as pneumothorax. It's important to remember that the performance or the image quality of the ultrasound depends on the sonographer's experience. So the more you practice, the more confident you'll be, the more sensitive the images are. There are a number of proposed protocols for how to incorporate an EFAST exam when you evaluate your patient after a trauma. And this is from the International Consensus Conference. So if you perform a FAST exam and the FAST exam is positive for intraperitoneal fluid and the patient is hemodynamically stable, they suggest getting a CT scan to evaluate the extent of injury and what is the source of injury. On the other hand, if the patient is unstable, the recommendation is that the patient needs to go to the OR for exploration of the injury. On the other hand, if you perform the FAST exam and the FAST exam is negative and the patient is hemodynamically stable, they recommend that the workup is at the discretion of the physician, either to observe or perform a CT scan. On the other hand, if the FAST exam is negative and the patient is unstable, they suggest looking for other sources for the potential causes of instability. For example, a C-spine injury with neurogenic shock. It's important to mention some pitfalls for the FAST exam. First of all, over-reliance on ultrasound. Ultrasound cannot evaluate retroperitoneal bleed or cannot distinguish solid organ injuries. Remember when we said the 4 important questions you're trying to answer is there intraperitoneal hemorrhage or not? We're not looking for specific solid injuries. Another important pitfall is delaying the transport to the operating room. When immediate surgical intervention is clearly indicated, such as evisceration injury, you don't need to do an EFAST exam. You can skip and the patient needs to go to the OR. Another pitfall is failing to scan the inferior pole of the kidney. The free fluid will start to accumulate closely to the inferior pole of the kidney, and if you don't interrogate that area, you might miss positive free fluid. Another pitfall is failing to recognize clotted blood. Patients with delayed presentation after thoracoabdominal trauma may have clotted blood rather than fresh blood. Therefore, the sonographic finding will not be anechoic or black, and they will have some echogenicity. Another pitfall is failure to understand other limitations of the EFAST exam. Morbidly obese patients and those with massive subcutaneous emphysema are challenging to image with ultrasound. Also, an EFAST cannot distinguish fluid type and cannot differentiate ascites from blood. Some pitfalls to try and avoid while scanning is not fanning fully. Incomplete views, remember that each view has potential spaces, so you have to interrogate that view to evaluate all the potential spaces. If the gain is too high, you might miss anechoic fluid. Underfilled bladder is another pitfall, as well as we went through some examples of pitfalls that you can misinterpret and call it a positive fast, including renal cysts, seminal vesicles, perinephric fat, and the stomach. Thank you very much for your attention, and here are the references used to prepare this presentation.